Welcome to the Core IM whiteboard animation on all things diagnosing peripheral arterial disease. This whiteboard animation, we will talk about how PAD presents, PAD risk factors, its physical exam features, and diagnostic testing. First, how does peripheral arterial disease even present? We are usually taught the classic claudication presentation. That is, lower extremity pain that increases in severity with exertion and decreases with rest. The reality is that only approximately 10 to 20% of patients present with this classic claudication picture. So how do the other 80 to 90% of patients present? Similar to atypical chest pain, approximately 30 to 50% of patients present with atypical peripheral arterial disease symptoms. Think of things like a vague sense of heaviness in the lower extremities, fatigue, and a tingling sensation in the lower extremities. Others may even present with hip and butt pain. Think of it as a buttocks claudication. What is humbling is that approximately 40% of those who have PAD may remain completely asymptomatic. So what specific history details can help move peripheral arterial disease higher on your differential? Pay close attention to 1, what exactly provides pain relief, and 2, how quickly they experience the relief. How the pain is relieved can help differentiate PAD from spinal stenosis, a common mimic, in that in PAD, the relief is provided with rest, while in spinal stenosis, the relief would come from leaning forward or sitting down. Second, patients with PAD will tell you that the symptoms resolve quickly, usually within minutes after resting. This is in contrast to yet another mimic, venous insufficiency, where the relief also comes with rest but can take much longer, approximately 15 minutes. So what risk factors should have your spidey senses higher for peripheral arterial disease? Risk factors for PAD include 1, age over 65, 2, current or former smoking history, 3, diabetes, 4, chronic kidney disease, and 5, hypertension. The most significant risk factor is smoking. Moving on to the physical exam, what can clue us in here? You may or may not see loss of hair and thinning of skin. The most specific physical exam feature is a good pulse exam. An inability to feel the posterior tibial pulse or the dorsalis pedis pulse is helpful in ruling in disease. But if you can feel these pulses, that does not rule out PAD. Patients with 2+ pulses can still have PAD for a number of reasons, including unaffected segments, incomplete occlusions, collateral circulation formation, or segmental disease affecting only parts of the arterial tree. Another key reason why the absence of a pulse is not sensitive is that even healthy people can have absent dorsalis pedis pulses and not have PAD. So which test can help us delineate PAD versus less likely PAD? That is where the arterial brachial index, otherwise known as an ABI, can be helpful. What is an ABI? To calculate an ABI, you get the highest systolic blood pressure in the ankle artery, either the dorsalis pedis or the posterior tibial, and the highest systolic blood pressure in the brachial artery, and you divide the ankle pressure by the brachial pressure. Once you calculate your ABI, there are 3 possible outcomes. An ABI less than 0.9 is diagnostic for PAD. The lower the number, the more severe the disease. An ABI between 0.9 to 1.3 is technically considered normal. However, similar to how a baseline 12-lead EKG could be normal in someone that has stable angina, these patients may require a functional assessment such as an exercise ABI to unmask underlying PAD. What about if their ABI comes back greater than 1.3? In this case, the elevated ABI indicates the presence of non-compressible arteries. These patients, often with a history of diabetes or chronic kidney disease, have calcified vessels, so their arteries do not compress, and the result is an inappropriately high ABI. In this case, you can consider a toe brachial index, otherwise known as TBI, as the next diagnostic test. A TBI of less than 0.7 would suggest PAD. So now that we have discussed PAD symptoms, risk factors, physical exam, and diagnostic testing, let's review. First, for the history. While we classically think of PAD as a patient presenting with lower extremity pain that is worse with exertion and improves with rest, consider PAD in any patient with lower extremity discomfort that has risk factors. Those risk factors include age greater than 65, smoking, diabetes, kidney disease, and/or hypertension, with a particular emphasis on smoking. Also, don't forget that patients with PAD may be asymptomatic. Second, the physical exam. If their story suggests PAD, focus on pulses. Feel their posterior tibial artery and dorsalis pedis pulse. If absent, that should raise your suspicion of PAD. However, if their pulses are present, remember, they can still have PAD. Third, for diagnostic testing, send your patient for an ABI. If the ABI result is less than 0.9, the patient has PAD. If the ABI is between 0.9 and 1.3, consider ordering a stress ABI to potentially unmask underlying PAD with exercise. Lastly, if their ABI is greater than 1.3, especially in a patient with diabetes or CKD, remember that they likely have calcified, stiff vessels that are unable to be compressed and may require a toe brachial index to diagnose PAD, specifically a TBI less than 0.7. Thank you for watching our whiteboard animation on PAD diagnosis. If you found this helpful, like and subscribe to our channel for more whiteboard animations. Also, tune into the Core AM podcast episode number 165, Peripheral Arterial Disease 5 Pearls segment for more information on PAD.